So now we're going to transition from an appraisal of the research evidence to what are we going to do with that evidence in a real life clinical setting. Now, this table has been adapted from Harris, Hicks, and Kasim, who set forth the ACP CDC clinical guidelines on the treatment of respiratory tract infection in adults. And we can see here that there's four primary presentations. There's acute bronchitis, pharyngitis, rhinosinusitis, and common cold. And for the most part, these are viral. Bronchitis is viral 90% of the time, and even when it's bacterial, it's often self-limiting. So no antibiotics are ever indicated for acute bronchitis unless it accompanies a pneumonia, but that's not the case that we're specifying here. Common cold, hopefully we all know that antibiotics are not indicated for that. All cases are viral. And that leaves us with these two in the middle, pharyngitis. So we're talking about a sore throat, perhaps a week in duration, maybe some fever, chills, fatigue, malaise. But even sore throats, in the absence of other symptoms, are usually viral. About 85% of the time, when they're bacterial, they're most frequently group A strep, can also be caused by group C and G. And we find that antibiotics may possibly reduce the duration of symptoms, but more importantly, help prevent rheumatic fever and suppurative complications such as abscesses. Now, it's important to note that rheumatic fever is actually exceedingly rare in the United States, especially among adults, but we still treat strep with antibiotics prophylactically just in case. With acute rhinosinusitis, we have nasal congestion, purulent discharge, sinus pain and pressure, fever and fatigue. It may last up to a month. Now, even with sinusitis, most of the time, once again, it's viral or of some allergenic etiology. In 2% of the cases, it is bacterial. There's some small benefit to antibiotics, but these are way overprescribed, way more than 2%. I think the statistic in the beginning of the presentation said maybe 60% of the time people get antibiotics. Unfortunately, sometimes they're often broad spectrum antibiotics as well. So we're going to focus on pharyngitis and rhinosinusitis and our possible application of these delayed antibiotic strategies. One note I want to make, though, is that these guidelines are not intended to guide the care of those who have serious respiratory comorbidities such as cystic fibrosis, bronchiectasis, and COPD. Also aren't meant to guide those who have immune suppression, whether they have HIV, renal failure, lymphoma, are recipients of an organ transplant. And these guidelines are really, really well set out and well put together. They're published in the Annals of Internal Medicine 2016. Very easy to search for, and I would recommend that all of you peruse them. They're very digestible and appear to me to be very well defended. So let's first consider someone presenting with pharyngitis. Now, this is not a lecture on clinical reasoning, nor am I qualified to teach such a course. However, I'm just going to sketch out our clinical approach to pharyngitis here. Um, the first thing to figure out is if it's viral or bacterial, and if it's bacterial, is it group A strep? And the answer is likely yes if it is bacterial. Or we need to keep in the back of our mind, is it some rare throat infection that's super serious and something that needs additional follow-up? So if it's associated with cough, congestion, conjunctivitis, hoarseness, it's likely viral, and the guidelines suggest that no further testing, be undertaken at the time. Now, if there's rigors, night sweats, rash involved, palatal petechiae, swollen tonsils, these are more suggestive of strep. We can be systematic about looking at these symptoms by invoking the modified Centaur criteria. No, it's not some mythical beast. It's a way to figure out if someone might have strep. Well, I say figure out. It's actually has much better negative predictability than positive. So it's better for ruling out strep than diagnosing someone that's having strep. But essentially, there's four different criteria, four different checkpoints here. The absence of cough earns you a point. Having tonsillar exudate earns you a point. A history of fever is a point. And this is just subjective fever. They don't need to be febrile in the office. And having tender anterior cervical nodes earns you a point. You also get a point if you're under 15 because you're much more likely to have strep. And you get a point taken off if you're over 44, naturally, because you're less likely to be in a population that we might suspect of having strep throat. So the ACP guidelines suggest, again, no testing for a Centaur score under 3. 3 or greater, we're going to do a rapid strep test, and most sources say that that should also be cultured. And according to the ACP guidelines, we're only going to treat strep if it's confirmed. Now, in the keep the worst case scenario in the back of your mind department, if they're having difficulty swallowing or drooling and they really have a toxic appearance, may want to think of possible Lemire syndrome brought on by Fusobacterium necrophorum. Very nasty. People develop septic emboli in their jugular vein, which can very quickly travel to the lungs and become PEs. So again, this is not a talk on that, but things to keep in the back of your mind to scare you. So let's approach 3 very simple pared down case studies here. First fellow, he's a 50-year-old man. He presents with sore throat accompanied by cough and runny nose. He said he's had it for 3 days. Otherwise, he feels okay. Denies fever and chills. Our second patient here comes to our practice. She's a 32-year-old woman with a sore throat for 4 days. She says it hurts every time she eats and swallows, and it's getting worse. She doesn't appear toxic. She has no cough. Cervical lymph nodes are non-tender, but she does have profound tonsillar exudate, possibly a mild subjective fever, although she is afebrile when she shows up in the office, and her rapid strep is negative. And finally, we have a 27-year-old man who takes Xeljanz, which is an immune suppressant drug for ulcerative colitis. He has had a severe sore throat for 2 days, along with extreme fatigue. His Centaur criteria score is 4, the temperature of 101.3 in the office, and the rapid strep is positive. So, our goal is to figure out for whom might a delayed antibiotic prescription make sense. And I kind of liken it to Goldilocks and the Three Bears, right? Got the cold porridge, the hot porridge, and the just right porridge. Well, when we're thinking about using a delayed antibiotic prescription, we're not going to use it with something that we know definitely does not require antibiotics. Someone comes in, clearly have a head cold, not going to use antibiotics. And by the same virtue, the sort of hot porridge version, we're not going to use delayed antibiotics in someone that we suspect to be systemically ill with a bacterial infection, or very clearly, let's say, having a strep throat infection. But we're going to use them for equivocal cases where there's some diagnostic uncertainty as to whether it's a virus or bacteria, exactly what's going on. So, using our Goldilocks skills here, proceed. And voila, these case studies were not meant to trick you. Pretty straightforward. I would assess that this middle patient here is the most appropriate candidate for a possible delayed antibiotic prescription. So our middle scenario patient from the 3 case studies, she had a negative rapid strep test, and we're still treating her. Doesn't that go against ACP guidelines? And I suppose it does. But rapid strep antigen testing can have a sensitivity as low as 60% in some cases. I've seen other estimates that say between 70 and 90, but it's not fail-safe. And cultures, have a much lower false negative rate, but still, it's possible. And I know as an ED nurse, often you get your swab and you kind of hope that you got where you needed to go, but I don't know. I am suspicious that there might be a bunch of uh, invalid strep samples floating around out there in the universe because a lot of it just depends on the skill of the person taking the swab and the ability of the patient to tolerate it. Um, so I'm a little bit more in favor of maybe going ahead and treating this person, but again, with a delayed antibiotic prescription. Uh, Also, in the case of waiting for culture results, follow up may be difficult. It may be difficult to get the person in for another full appointment. Um, so, guidelines in the United Kingdom, published by their National Institute of Health and Care Excellence, or NICE, they recommend a 3 to 5 day delay for pharyngitis of uncertain etiology if they have a Centaur score that our case study lady had. So we're going to delay, and now we're going to talk about how we're going to go about that delay. Okay, so I just want to fill you in on something I was a little bit inarticulate about on the last slide. The UK guidelines for delayed antibiotics in sore throat suggest using that 3 to 5 day delay for a Centaur criteria score of 3 or 4, which is, um, relatively speaking, similar to the ACP guidelines, although they don't allow for any particular delay. So, how are we actually going to approach this patient if we want to give them a delayed prescription? Well, let's write the prescription, write the correct prescription, which, assuming she's not penicillin allergic, we can do oral Pen V, 50 milligrams twice a day for 10 days. And then you may remember earlier I said that the CDC sort of implicitly endorses delayed antibiotic prescribing strategies, but it's not part of any of their guidelines per se. Well, this sheet is an extremely useful document that I would keep on my desk if I were a provider. It gives instructions. You fill in how many days you want the patient to delay for, and it says if you don't feel better in X number of days or you feel worse, go ahead and fill the prescription. And then it also just has a little blurb about the side effects of antibiotics. So I think it's a great way to sort of connect with your patient, go over this sheet with them. That way they have something to take with them and refer back to. And we're going to give this young lady a delayed prescription. In addition to the CDC sheet, going to reinforce a few things. First, on average, antibiotics only shorten the duration of sore throat by 16 hours. Most people feel better within a week, whether they take antibiotics or not, and that complications are really quite unlikely, even if it is strep. But recontact the office if they're feeling really significantly worse, absolutely lousy, particularly if they have fever and chills. So then we'll file the prescription at the front desk, and it will be available in 3 days if the patient needs it.